Thank you. Assalamu alaikum wa rahmatullah. Good afternoon, everyone. My name is Dr. Abdulrahman Alqahtani. I'm the head of interventional cardiology at King Fahad Medical City. I'm presenting live in a box. It's a TAVI case, along with my colleague, Dr. Fahad Alqahtani, who's an interventional cardiologist as well. Are we good to go ahead with the slide? Okay. So I will go quickly through this because the video will start afterwards. So we had the pleasure of dealing with this lady, 76-year-old lady, who had a background history of dyslipidemia, hypertension, type 2 diabetes. She also had a vertebral fracture, lumbar spine surgery where she had a fusion, also left with some scoliosis as a result of that. She also known to have coronary artery disease. She had BCI, dedicated bifurcation BCI to the mid-LAD D2, extending all the way to the left main with IVAS-guided procedure. She also had a BCI to the ostium of the RCA and mid-RCA. This lady presented with heart failure symptoms, basically, and was found to have severe aortic stenosis. Her STC score was 8.2. We'll skip through that. Echo, as you can see, restriction of the aortic valve. There is evidence of LVH, and it's trileaflet and with evidence of calcifications. No significant AI, and the gradient was reaching 40 millimeter mercury. So this is the angiogram before the intervention was done previously. You could see the ostial RCA disease and the mid-RCA disease. And you could appreciate the disease in the mid-LAD with the diagonal. Dr. Fahad Alqahtani, who's sitting in the front here, did the intervention on this patient, dedicated DK crush procedure to the mid-LAD, and then he did an IVAS to the ostium of the LAD and left and was also significantly diseased, so an intervention was done. This is the final picture, and this is the final picture of intervention on the RCA. So this patient has a mean annulus diameters of 19.9, which put her in range for 26 core valve Evolut Pro. The sinus of alpha diameters and height were appropriate. The height of the left main was about 12 millimeters, and the right coronary artery was about 14 millimeters. The things that to appreciate that there was calcification, significant calcification around the branches of the arch. Also, there was evidence of significant tortuosity, as you can appreciate in the left common iliac and also around the distal part of the aorta. And that's made it a bit challenging to do this case, especially from an access point view. You could appreciate the degree of the angles of the distal part of the aorta and at the level of the left common iliac. We also decided to go on the right side for that purpose. There is also high bifurcation there. So this video is supposed to play right now. But things to consider in this patient, basically the tortuosity of the peripheral arteries and how to overcome them. Also, this patient had spinal deformity, scoliosis. He was not able to lie flat. She needed to have a wedge, and this changed the position of the patient during the procedure. The presence of coronary artery stenting, especially ostial RCA and left main, and the calcification of major branches. With this, I'm concluding, and we're going to start the live in a box case. You could start the video. The first aspect of this case, would like to show you a different alternative approach for doing transvenous pacemaker. This will be through the basilic vein through antecubital fossa. You start basically by establishing an 18-gauge IV cannula in the antecubital vein, and then exchange it to a regular 6 French radial sheath, and through it you could advance your 5 French pacemaker. So this is what we're going to be showing you right now. As you can see, you can take it all the way there, and then if you face resist, balloon up. Yep. Yes, balloon up. It's up. Okay. So now we're going to show you that it is sitting in the RV, and it's been placed and tested, and it's working fine in this spot. Next step, we're going to establish access on the femoral axis for both the left for our diagnostic pigtail, and also on the right for our TAVI axis. I need the Lido, please. So once you establish your access point, you could confirm your trajectory and entry point on the ultrasound. You can see it here. You can see my needle coming as you can see, and this is my needle coming, and it's just above the artery, and I'm gonna gain puncture right now. So stop there. We're right above the artery, so we're gonna gain entry point now, and we just made an entry to the artery. So the same goes for our entry for TAVI. So we determine the access point based on the ultrasound guidance. I'm currently on top of the artery, and I'm gonna just puncture. And as you can see, if you focus here, you could see the flow of the blood pulsatile, suggesting that you're in the true lumen. And after establishing the access, we will insert this 4 French size micropuncture sheath. Okay, so you screw it in just because it's not very, the tensile strength is not very strong, so you just screw it in. And then, as you can see, the blood flowing, and you connect a contrast syringe to it to determine the location. So then we take a cine of the angiogram determining the entry point, and as you can see, we have a very good entry point in the upper third of the femur head and also central position. So we have a very good spot. Okay, so pull the table back, Salim. Okay, so now we exchange for a 6 French sheath. Normally at this spot, at this time of the procedure, okay, so 6 French go first, okay, just to dilate, and then everything comes out, and then we use the Bro Glide to pre-close the arteriotomy site. So everyone, we normally in our practice here, we use a single Bro Glide and we close with it. And if we needed a second Bro Glide, we add at the end of the case. Okay. So in order for us to place the cerebral protection device, in this case is Sentinel, given the calcium burden around the arch and also the origin of the 3 branches of the arch, we will place a Sentinel through a radial approach. And in order to do that, you need to have also a big tail demarcating the innominate artery. So now we determine the origin of the innominate artery. We are going to go ahead with the Sentinel devices. So we're gonna advance this through a 6 French radial sheath, and under fluoro will guide it with a BTC wire, with the coronary wires into the ascending aorta, and then deploy the first basket, and which is the proximal basket, and then curve it into the left common carotid, and then deploy the distal basket in this situation. Okay, follow. Okay, centralize us. Okay, hold it there. Okay, hold the wire. Okay, so we coming through. Okay, so I'm gonna fluoro again. We coming through with this. I need you to store this. Okay, so until we get into this marker. So the marker we see on the screen right now is a marker. Come down with the table, please. No, toward you, Salim. Toward you. Yes, stop. Okay, so you could see that this markers. As you can see, what it seems to be a snare there, it's located in the proximal segment of this catheter. This is the proximal basket, and now you can see that the tip is almost in the ascending aorta. So as you can see here, the proximal basket is going to be released now. Dr. Fahad is doing this. Okay, you can see it opening now, and it's opened, and it's in a good position. Now we have the wire in the left common carotid, and we have the catheter also situated in the left common carotid. Now what we're going to do is basically deploy the distal basket by pushing knob 3. Go ahead, Dr. Fahad. Okay, you can see it on the screen coming up nicely. Keep going into this position. Okay, keep going a little bit. Okay, fantastic. This is a very good position. And now we're moving along with our case. So what we're going to be doing now is obtaining our angiogram for both angles, 3 cusp views, and also overlap views. So we're going to take those angles. We have already determined that by our pre-processing of the CT result, and we'll go ahead with that. Okay, first angle. So what we're gonna do now is basically advance an ambulance wire, it's stiff wire, just before delivering our 16 French sheath, just in order to straighten that curve that we see in the abdominal aorta and the lower part of abdominal aorta, and also to avoid the effect of tortuosity in the situation. So I'm taking an ambulance catheter and we'll advance the ambulance stiff wire through it. And if it doesn't work well for us, then we have Linderquist as a backup in this situation. Now you can see that we have crossed the tortuosity. We're gonna exchange to 12, and then after 12, we're gonna do the 16 French. Okay, ready? Currently, we're gonna go ahead now, and under fluoroscopy guidance, we're gonna see how this will fly with us. Okay, follow me up. Okay, so we have some resistance here, but we're fine. So show me up, keep up. This is the tortuosity. We're going around the tortuosity. No problem, and we straighten, as you can see, we straighten this area. Okay, so we brought now ambulance catheter again to cross the valve. In order to cross the valve, different wires can be used. I personally prefer to use a straight tip wire. There we go. So we will try to get the wire to curve sometimes in a better position. So I tend to bring it back and try to get it into curve in those situations. Okay, so here we're having a good position. After we get our big tail inside, we do simultaneous LV aortic pressure measurement. So we'll stay here in this position because I care about seeing that the wire does not go. We're going smoothly. We're going smoothly so far, no issues. Okay, and we're coming across. We have managed to overcome the tortuosity in the mid aorta with this wire. So now we have placed our valve across the aortic valve. The angle that we are trying to achieve is not optimal due to the spine deformity that she has, and also the spine issue. The patient is lying on a wedge, and therefore the angle that we found eventually that will work for us is almost RAO 35, caudal 35. And that's what we will be trying to deploy on. As you can see on the screen here, you could see that the valve is positioned in this way. And it's not our conventional way of seeing the valve coming this way, but we have closed our parallax in this view, and we will start deploying in this angle, which is RAO 35, 36, caudal 42 now. Despite, despite that we are a bit low, but given that we have a stent at the ostium of both artery, mainly the coronary artery, there's a stent extended on the left main. So we would tolerate a little bit of a low position in order to make sure that we increase the space for the sinuses to have a good flow into them. Okay, so we're gonna be deploying the valve right now, okay? Dr. Fahad, ready?
Ready.
Okay, pacing ready?
Yeah.
Okay, so go ahead. So now we have deployed the valve. We'll take 2 pictures just to see if there is any paravalvular leak, and then we'll take the system out, cross with the big tail catheter, do gradient after that, and then we'll bring our echo colleagues to do a formal assessment using a transthoracic echo. As you can see on the monitor, that's when we place both pressure, the LV pressure and aortic pressure over each other, there is 0 gradient. We cannot see any gradient. Thank you so much. So now we can be confident that there is no issue relating to the valve in terms of, number 1, there is no remaining gradient. Number 2, we don't see any paravalvular leak that could be assessed. If there is such a thing, we will be considering the diastolic index in this situation. Now we're going to move ahead, and we're going to close our arteriotomy site, or the TAVI access site, and we use only 1 Bro glide, and we're going to go ahead and close it with 1 Bro glide. One thing to mention, that the patient basic rhythm remains sinus rhythm after deployment in this valve, and there is no changes that we notice. That will require the pacemaker to remain in, so the pacemaker will be withdrawn after we finish this case. So what I'm doing, I'm just wrapping the thread around my index fingers on the right hand, and I will be controlling the bleeding. So Dr. Fahad will go ahead and remove that, and we'll maintain just the regular J wire in this situation to remain in place. Okay, keep going. keep going. Okay, and as he coming out, I'm applying just tension on the wire, and as you can see, I just deployed my knots, slid it all the way to the top of the artery. I'm maintaining tension, and then I checked for bleeding. There is a bleeding. I just put some more tension. Okay, I want you to take the wire on my count. Okay, go ahead, take the wire. Okay, so deployed it further, and now we're gonna lock and advance it and basically carry it at the skin level, and we just apply pressure, please. So now we're going to remove the cerebral protection device, the sentinel, the situation, and the process basically is reversing what you've done. So basically you capture the distal basket first, and then you advance the whole system into the aorta, and then you bring it back and retrieve the proximal basket, and they take the whole system together with the wire as one unit. And you give protamine after you do that. You need the patient to be anticoagulated during that process. Okay, ready, Dr. Fahad? So under fluoro, okay, show us. Come back, just bring the table toward you down, yes, Salim. Okay, stabilize here. Okay, so you could pull, advance the wire a little bit, then pull number 3. Okay, yes, keep going, keep going, keep going, keep going, fantastic, keep going, fantastic, all the way, fantastic. So now you could pull the system slightly, yes. So we bring the system together, we close the second basket, the proximal. Now you just retrieve the whole system. And if we find anything that has been retrieved, we'll show it to you at the end of the case. So this is an example of the debris that we have collected from the left common carotid in this case. If you zoom enough, you could see the degree of the debris, and those are remnants of calcium likely embolized from the aorta or the valve. How much would this affect the patient is hard to say, but based on trial that has evaluated this, there is a decreased risk of stroke with those patients, and the degree of those embolies to cause a clinically meaningful effect still under study. Currently, we are removing pacemaker. Again, it's through the right antecubital vein, the entry point, and once we remove it, just a small amount of pressure for a few minutes, and that will be the one dealing with it. Okay, so so the last step is we're basically going to take a picture of the peripheral vasculature in the right femoral artery, making sure the arteriotomy site is not having any issues, and we're going to take a peripheral angio right now. Okay, go ahead, inject. So we could see a very nice flow, no significant stenosis, the entry point is intact, and we don't see any clot there. So this is just to show you the axis sites that we have used and what they look like at the end of the case. So we have a left femoral for the big tail, femoral artery for the big tail placement, a closed angioceal, and we decided it was 6 French venous sheath for a central venous axis. There was nothing in the neck or the inferior jugular, and you can see it's clean. This is the side that I want to show you the most. This is how big the entry point or the skin cut that we use. This is less than 1 centimeters. As you can see it here, this is what we use to access the femoral artery for our TAVI procedure. So this is closed with 1 glide. After that, we checked checked that it was intact and there was no stenosis. And we get protamine, and you can see what it looks like with only 1 glide. This is our access site here for the 6 French venous sheath that we put here. It's a radial size French sheath that we use for the pacemaker placement across the antecubital vein. And this was our radial axis, 6 French, for the sentinel device that we used. And as you can see, so this patient is going to the recovery room completely D-lined. There is no lines remaining, and that will enhance and encourage early discharge and early recovery for those patients. Thank you. We conclude our case today. It was a challenging case in many aspects. Number 1, the tortuosity of the aortic artery and the significant degree of calcification. Number 2, the patient has a spinal
problem with the spinal fixation before at the lumbar spine that didn't allow us to get a very good angle, as the patient had to lie on a wedge throughout the case. Also, we attempted to prevent any risk of a stroke in this patient by using cerebral protection device Sentinel in this situation. We also showed you how to do a different alternative approach that is minimally invasive for the pacemaker placement through an antecubital vein. And lastly, that we still can do most of TAVI cases with a single bro glide approach, and as we showed you that there was no significant complication from that, and we managed to do that. The case went well throughout despite having all those difficulty, and the patient remains stable, and she will go back to CCU for recovery and likely will be discharged home tomorrow with no need for pacemaker so far. Thank you, and thank you for the team. Thank you for ICOM and the organizing company, for Medtronic, and for GIS for having us for this case. Thank you all. Thank you.